Hi, Jordan. Great to have you here.
Great to be here with you. Hope you're doing well.
Very, very, and excited to get to unpack with you one of the least well understood and also most powerful stakeholders in US healthcare, risk-bearing integrated delivery networks, or what some might call payvidors. But before we get into all of that, let's kick off by hearing a bit about you and your own background within this space.
Sure. Well, thank you for having me. My name is Jordan Asher. I'm an internist by trade, born and raised in Nashville, Tennessee, and grew up from a clinical perspective, running a large multi-specialty group in Nashville. Then moved on and worked for Ascension Health, really focused on population health and combining their health plan along with what I would call their population health management company to really try to deliver on value. And this was really, 2000, starting in 2011, so really early on. Then more recently, I moved to Centera Health, where I have semi-retired from, and enjoyed a great 7 years there. Really focused on how to think about a large regional health system that is a true integrated delivery network. And what I mean by that, it's when you have a health system that has both a health plan and so a financing arm and a care delivery arm, and it's critical how those work together. And at Centera, we were very focused on how to make that work as a single entity in order to deliver the greatest value to those that we serve.
Yeah, and Centera and your role there, your tenure there, is unique and so I'm excited to dig in. At a high level, to remind the audience and ourselves, this interview is meant to serve as a companion to the IDN as Buyers field manual that we co-created. If you haven't downloaded it yet, you can grab it at lionbird.com/IDN. It'll make this video easier to follow. And really, we wrote it because if you are a company selling to providers, health plans, or value-based care entities, you'll eventually run into risk-bearing IDNs like those you've worked at, and they control a massive share of how U.S. healthcare is paid for and delivered. But they're complex. Success is not only about having a good product that's important, but you also really need to understand how these institutions work, who makes decisions, where budgets sit, and the invisible forces that can kill the good ideas before they scale. And so the manual we created is not a sales playbook per se, but more about asking the right questions that help uncover why an IDN behaves the way it does, which is not always understood. So,
Yeah,
yeah.
and I want to add on to that. As you go through it, and as you talk to IDNs, you might step away and say, "Wow, they really seem to be in conflict with themselves," and that's exactly right. I don't call it conflict. I call it, to Jonathan's point, managing the complexity of being on both sides of the ecosystem when historically those sides were meant to be in conflict with each other. Our health system was set, our not our health system, but our healthcare ecosystem was really created to be a little bit at odds with each other to keep a balance from a market share perspective. And so, hopefully, what we'll talk through a little bit is around how IDNs are looking at that complexity and saying, how do we manage that complexity to really deliver on value, where value is quality plus service divided by cost or affordability?
Yeah, and it's a great lead in to the first question. Academically speaking, the value of integrated care is clear and very exciting, but there's many other, from a business strategy perspective, many other reasons historically why you would see many providers move into sponsoring payer arms and starting to integrate these two types of entities. And so it would be great to explain to the audience, what are some of the other reasons IDNs exist? What are some of the business strategies behind them? Why are we seeing an increase in combining these payer and provider arms?
Sure. And it's a great question. And I'm going to start out by really trying to say, okay, in the US healthcare ecosystem, there are a bunch of different, what I call categories that feel like they, quote, own the person. Okay. And so you have payers who feel like they own that relationship, that consumer engagement, because their payers are ultimately the ones that hold the financial risk or that are in the payment process. The problem with the payers being the center of gravity is payers do not deliver care. Okay. So no matter how much they control the dollar, they don't deliver care. So they're always looking to figure that part out. And then you have hospitals or hospital systems that are obviously deliver care, but in reality, they can't own you as a consumer because they only take care of a small sliver of the population at any one time. And they only take care of you for a moment in your own time. So even though they're delivering care, high cost care, and needed care, they can't own you because they're just a small sliver. And then you have physician groups that have the relationship with you. So they feel like they're more of that consumer owner, but in reality, they're not either because you don't spend a bunch of your time at the physician's office. Plus, most of health and wellness is outside of the clinician direct realm. So then you have intermediaries such as clinically integrated networks that are trying to sit in the middle of that, work with all the different components to deliver value, but they're really just an intermediary. And then you have what I would call the outside people, the Amazons of the world, the Googles of the world, and because they think they own that relationship, but because they know you better than anybody else, which is very true. However, they're not on the payment side and they're not on the care delivery side. So when you think about all those centers of gravity, in reality, it's not any of those individually, it's how they work together, different pieces of the puzzle, with the right answer being that puzzle or being that quilt. And so IDNs are health systems, our historical providers, our care delivery units say to themselves, okay, we need to we are part we have a couple of those centers of gravity. How do we bring the other ones together to really create products to get at first dollar from a payment standpoint, to own the quality on both sides, to own the service, to really deliver on a product standpoint that is different than just the individual pieces can. And then as they become more innovative, they get into that space that the Amazons and the Googles and the Microsofts want to play in as well. So conceptually, the I the hypothesis or the thesis is that as a care delivery model, if I get on the financing side, bring those together, then I could deliver a better product, higher quality, better service at a more affordable price because I am on both ends and I see everything, I feel everything. The hard part is no matter unless you're a Kaiser of the world, most IDNs, only about 20% of their care delivery business is on their payer side. So you still have to live in the world as a independent payer and as a independent care delivery unit, meaning I've got to take care of people from other that are financed through other health plans, and the health plan has to deliver services at other locations other than its core care delivery arm of the overall company.
Yeah, so a lot of different silos within that are kind of pulling in their own direction. It all sounds great in theory, but in practice, very hard to actually integrate that puzzle and realize those real synergies. And so I think this is a critical point. You know, many people might assume that being both a payer and provider will make coordination seamless and incentives aligned, but more often than not, the reality is messier, and that's what part one of the manual really dives into. And so I think it's interesting to kind of go one level deeper and to touch into more examples of why that integration proves so difficult in reality, whether it's about incentives or regulations or any other kind of operational challenges of realizing those synergies.
Sure. And so I'm just writing down some, you bring up some great points I don't want to miss. As we think about this, the the core the core business of a payer is how to take a dollar out of somebody's hands, i.e., an employer or the government, how to create a margin for itself and pay the for healthcare. Okay, just it's just an in between in our, because remember, for us we call them insurance companies, but they're really not insurance companies. They're insurance slash management of health companies. Your car insurance does not Our car insurance does not pay for changing the oil or tire maintenance or car washes or anything like that. Our healthcare insurance pays for maintenance, so it is more than just insurance, it's a maintenance plan. The other issue we run into is that as a payer, if I'm trying to decrease the overall cost of care, the people are not with me as an insurance company for a long period of time necessarily, because our market is so mobile, meaning people move around jobs, which means they move around insurance companies. So unfortunately, insurance companies are in this conundrum of saying, okay, how do I negotiate a rate to make sure that I'm able to do my business? I can't always just worry about their health care because I'm not going to keep them long enough to reap the benefit of it from a financial standpoint. And then you have the payer side that is saying, okay, I get paid on every time I do something. And so me managing not to do something is not necessarily in my best interest. And so therefore that keeps that tension. But there's another value that none of us really talk about as IDNs, is that, remember, an insurance company has to bill a care delivery provider. Okay. Let's call it a hospital. And then a hospital has to bill for for its work, and a payer has to pay for that. There's a ton of money being spent in that administrative function. So when you have an IDN, you're basically billing, your right pocket is billing your left pocket, and your left pocket is collecting from your right pocket. So there's value in the administrative side in working together because you're the same pot of money at the end of the day. So we get this polarity because when you grow up in the insurance world, you're sort of taught to think how to work with with care deliveries or providers. And on the provider side, from a financial standpoint, you're trying to optimize your payments from the payer, and the payer is trying to optimize its paying for care, but paying the correct amount in their eyes. And so uh, when you think about how you have to come together, and as you work with an IDN, there's the level of structure. How is the IDN structured to work together or not? Are you in fact having to deal with two different sub companies of a parent company? And then you have talent. How progressive are the people thinking about the future and what a true IDN can bring? Because if they're future thinking, that makes you have to think futuristic in the standpoint of how am I helping them get to where they want to go with whatever product I'm using, because it might look different in a fee for service world than a capitated world. And then lastly, IDNs have to think about their process of how they work together. and choosing products that, in fact, help them on both sides as a total, and can work within a value-based arrangement or a fee-for-service based arrangement. So as you begin to think about product creation and service delivery, keeping those dynamics in mind becomes very important.
Yeah, you really have to meet them where they are and not just assume all those synergies that you spoke about have been fully realized. But
Correct, correct,
there's
correct.
a lot of nuance as to which business line or which payer line or what kind of lives they're covering. And so I want to actually go even deeper. You mentioned it could be two distinct entities under one corporate umbrella. And, one of the more non-obvious challenges of integration would be the regulatory, in the sense of, if you're ideally you would be sharing claims data or care utilization info between the health plan and the provider side, but that may be complicated under regulations, and then also, it may be difficult when you're talking about Medicare or Medicaid guardrails, for a plan to be giving undue advantage to its own provider arm around the things like the administrative functions that you mentioned, like utilization review, network adequacy, and fraud detection. Is that, sometimes an issue, or is this something that is, you know, able to be figured out and overcome in these IDNs?
Yeah, well, I'm never going to say the regulatory environment is not an issue. It's always an issue. But IDNs have gotten very good at navigating that and creating the guardrails that they need. They all have very good legal and compliance arms, and their focus is to do it the correct way. I know of no IDNs that are saying, "Oh, we're going to skirt those regulations." Okay, the people you work with take it very seriously. However, the regulations are all not always black and white, and they're not always tested. And then we have things that are called safe harbors. And so what you will find is that even though you heard what I said, you might find some organizations that are more conservative and some that are less conservative on their own interpretation of the regulations.
Sure.
And that's just a dynamic that is real. The ones that are less conservative aren't trying to get around it. They're just sort of looking at it differently because there's regulatory and legal risk, and then there's business risk. And depending on how conservative an organization wants to be, sort of does that dynamic. But at least in my opinion, all US IDNs really take that into consideration and follow those regulations and regulatory environment. What you might just see is once again that schizophrenia where you might hear one day, well, we can't do this for this reason, and you go to another organization and they don't have an issue with that at all. It's really on how they interpret it, and you'll just have to get a little bit of a feel of how where they fall on that spectrum, driven by their compliance and legal frame of mind.
Sure. And I guess the takeaway for someone trying to sell to these organizations something more progressive that is taking advantage of some of these, selling to both sides of the business, legal and compliance is going to be a key stakeholder in that conversation. And
Yeah. Yeah.
yeah,
And the good news is when you think about product that's delivering value on both sides, that that really shouldn't cause an issue because the regulations are really how do the how does the payer side and the care delivery side work with each other as relates to patient information data sharing in order to not to get into all types of antitrust issues and lots of other things. However, uh, for example, if you are selling to an IDN, there is no regulatory issue that says, hey, the people on the health plan side and the people on the care delivery side can't be in the same room. That is not true. So if they're not, it's because of their internal structure, not necessarily a regulatory rule that says they can't even be in the same room. If they take that approach, then unfortunately you're talking to both sides separately, which makes it harder. But there is nothing in my head. I mean, there might be certain times and certain products, but for the most part, if you're an IDN, you could be in the same room.
That's great. And speaking of variability between IDNs, culture is always interesting, and often the history of an organization, where it began, has downstream implications on their path to integration. So some risk-bearing IDNs were designed from the ground up as integrated payer provider systems. Others bolted on a health plan later, sometimes to diversify revenue or go after more of the healthcare wallet. From your experience, how much does that origin point matter in terms of future integration challenges?
I think it matters a lot. And I'm going to talk about two extremes. You have the Kaiser model, which was a pure health plan that says we could do better on the payer side by owning the care delivery assets. Okay. And then you have on the other side, to your point, health plans that say, I mean, I'm sorry, hospital systems that say, oh, I want to be in the health plan business to try to get that first dollar. Okay. And we're going to keep them separate, and we're just looking at it from a portfolio perspective. uh, and then a lot of the other ones fall in the middle. The problem that why and figuring out their history is important, only because how well did they begin to think about their coordinated structure from a reasoning to do it. So if you have a health system that says, I just bought the hospital side so I can control my payer costs, or I just bought the insurance side to try to negotiate a better deal or to try to get a different revenue perspective, versus saying, no, we saw the value to what we could deliver to the consumer by coming together. So understanding that is very different, because then if you figure out if it's one of the three, you sort of also have to figure out what's the stronger arm, because they will be the one that you will have to, from a hooks perspective, really show your value. So if you go to an IDN that is very care delivery centric, and you start talking about the value for total cost of care, that's not going to resonate with them. Versus if you talk to a very strong risk bearing insurance entity that is, and you start talking about the value it might bring for care delivery, they might say, wait, we want to talk about total cost of care
Hmm.
type of thing. What you'll find is that you just have to do that digging so you could uh, change the framing of the conversation. A lot of companies ask me, well, do I have to adjust my product for the different models? And my answer is usually no, because if you truly have a good product, it should work in any environment. And then it's more about talking about and framing the value within the environment you are in. Uh, Now, there's some products out there that really say, okay, we're going to help you do this to optimize your payer contracts. Sure, they're going to be extremes, but if you're focused on delivering something that improves the health and wellness or the life of a consumer, it should work in both situations. It's really about how you frame it and how you have those conversations. And this is why I think, Jonathan, what you're putting together is so helpful. It's to help figure out what those conversations are and how to learn about, on a consultative manner, get a better idea of who you are sharing the value you bring with.
That's a great point, and the manual has a few sections that go through the history that allow you to ask the right questions to understand where the organization originated, where the kind of centers of power may be, and yeah, I love that advice that the product may stay the same, but you need to tailor the messaging as it's going to be different depending on which organizations hold more sway within the IDN. And it's kind of bringing us to another good point. Often startups think they're selling to a Centera or an Ascension as though that were one entity, or a Kaiser, but healthcare really is local and dynamics can vary wildly market to market within even the same parent company, which is covered in part 3 of the manual. In your view, what should founders know about this? Maybe give us some real life
Yeah.
examples.
So it really, and I think this is true. Let's take out the payer provider conversation here. I think your question is really a good one when you're talking about large organizations versus very small organizations. Okay. Or they could be very big, but very localized. So the large national players, you have to remember that for us, healthcare is still very local. And so, how centralized a company is versus decentralized is very important for you to figure out. Okay. Because you might be saying, oh, I'm talking to, company X that's in 25 states. All I have to do is talk with company X and it works for all 25 states. You could be in a situation where that's completely not true. You talk to one in one area, and then you think, okay, I sold them. They see the value. That means it'll be easier for all the other 24. And then you come to realize, oh, they don't even talk to the other ones.
Hmm.
They're completely so. It's the same concept of figuring out how broad a reach and are they looking. I'm a big believer, and you can, and this has been on the other side when you're talking about the polarity or the managing the complexity of centralization versus decentralization in a large company. Um, at the end of the day, you have to understand that there are important points to pull out. Same is true on the payer provider side. The first question is if you're talking to the local entity, is figuring out do they have decision rights? Because you can get them bought in, but they don't ultimately have decision rights. And so if they don't have decision rights, that's okay. But then you have to figure out who you have to help them get permission from to do it. Okay. Then you have the other end of the spectrum where you would be negotiating with a me who then has to go tell people to use it. That does not work either. Okay. You might say, this is great. I have sold to the top guy. He said yes, but no one's using it. And that's because at the end of the day, if I don't get buy-in from the end user, the product's not going to work. This is very true in the IDN world, okay? Because you can get the payer to say this is great, but they did not include the provider side, so the end user doesn't necessarily going to use it. And then you have the opposite of saying, I got the end user to want to use it, but it doesn't fit with what the payer side wants to do. And so understanding how they work together, how their decisions are made is very important so you can know who to ask to have in the room or not get frustrated and just know what the step process is going to be. And so that concept of local versus national or regional, because even a regional health system using Centera, for example, has 12 different markets or has multiple different markets. Uh, and so obviously selling to a single entity in a single market is great, but IDNs don't work like that. But I think this conversation is true both on the IDN perspective and decision making, but also as you think about the complexity of large health systems in themselves.
Hmm. Yeah. And commonly you'll see that these organizations are structured around geographic markets versus service lines? And is it fair to say then, if I'm continuing upon your line of thought, that the economic sponsor and the champion may reside in different parts of the org, but you're always going to need to actually engage both of them, just on different fronts or different, yeah,
That's what I, unless there's been such good distributive model where it's pushed down, which does not happen.
yeah,
Okay.
yeah,
And you made another great point, is that even though I might be a payer and a provider in a market, in multiple markets, our geographic, our meaning healthcare geographic models are not mature enough to be designed by the commonality or the over possible business in a market, including both of those. Even within the market, the health plan side and the provider side are still separated. So I don't know of many IDNs at all that, and some are trying to get to this point where their market is defined as total possible business, regardless if it's care delivery or health plan.
interesting, yeah. And so speaking, continuing on local market dynamics, as an IDN, often what you'll see is some zip codes are further ahead in aligning their provider and payer arms. Maybe they'll have a higher overlap of patients as members, while others are further behind. What are the kind of unique assets or attributes of an IDN that you'd want to look for as an innovator trying to sell to these groups that may signal that they're further along in that overlap on a regional level versus maybe earlier in the journey?
Yeah, but what I like to suggest, and I think it'll give you a good idea, is whomever you are talking to, asking them what is the problem they are trying to solve. And that will give you a very quick indication of from what angle they're coming at it. Okay. Uh, and a true IDN will answer this very differently than just a company that has a payer side and a provider side. And you might be talking to the payer side, you might be talking to the provider side.
Mm,
And then, knowing that they're an IDN and you hear what their problem is, then you could ask a follow up question of how important is this for providing value to the other part of your IDN? And then they might go, "Oh, you're right. I got to think about it that way."
mhm.
Okay. Or they might not, or they might say, "I don't care." Right.
Just a
You can get
litmus
all types
test.
of,
Yeah, if they're even, yeah,
but you've teased out, so you're not, what you don't want to do is sell or talk about a broader concept when you're talking to someone that is only focused on an individual issue. Or the other way, you don't want to just talk about an individual component when they're really trying to think about the broader picture. And to my point earlier, what you are talking about, I'm sure likely works for it all, but knowing and framing and figuring out which door you're entering is incredibly important.
absolutely. And so tying this section together before we move on, we've talked a lot about market segmentation, how to really understand or qualify where an IDN is on their journey of integrating, and how viable of a target they are for your startup's innovation, and what to consider when you're messaging and who you're speaking with. Are there any other is there a mental checklist or some other important questions that we didn't discuss that you think are critical for an innovator to explore up front? Uh, Anything that was covered in the IDN cheat sheet before we kind of move on to the next section?
I think it's funny. I think it's first asking yourself where you believe your value is, and what you think the problem is you're trying to solve. Because I think knowing yourself is very important. Because the question as a buyer, I hated the most is whatever your problem is, we can help you fix it. Right. or tell me, tell me the things that keep you up at night. And it's like, no, let's do I want to hear what you are focused on. I will let you know if that fits, type of thing. you know, or even saying, this is the problem we are focused on. Is this a problem you have?
Yeah, no, that's such an interesting point, is balancing the consultative sale and tailoring your message to each stakeholder, but you still need to stand for something and have some sort of mission
That,
because everyone's coming in like that. And yeah,
yeah, that's exactly right. And the people that do, in my opinion, that do the best understand what they are trying to do really well versus trying to focus on how to get a dollar out of my pocket. Now, understand, from a startup standpoint, you got to create a revenue stream, but
sure.
really knowing what you are. The other is, you're going to walk this very fine line of helping me understand my business in a different way without calling my baby ugly. Okay. You can't make me feel stupid, but you also have to, you're likely trying to get me to use your product that is doing my workflow easier. Because regardless of who you're talking to in an IDN, the first thing that is running through their mind is, how do I integrate this into my today's operation? Which is really backwards, because a lot of times we should be thinking about, how do we change our operations to fit with a new way of doing things? And so the example I like to use is when Henry Ford, who created the Model T, which was really the precursor to all our automobiles, if he went out and asked the customer, what do you want or what do you need? They would answer, a faster horse,
Yeah.
versus, oh, an automobile that runs differently. So you're going to have to walk that fine line of consultatively understanding, not to sell, but to be so broad, but to really say, okay, this is the area we are focused on. As we grow and mature, yes, we can do all that. And the other big thing that I'm warning everyone about is, everyone's going to say, can you do it this way? And there you're going to say, sure, we can customize it for you. Mass customization is very hard to scale. And so being flexible is great, but being over flexible will create an issue for you. And the example I like to use, which is nothing I've had anything to do with, but in 1993, I was a resident at Vanderbilt University, and we began to work on its EMR. Okay. And we created, I was only there a year, but they created their own internal EMR that worked great for Vanderbilt. A big company then came in and bought it and tried to scale it, and failed miserably because it was so hyper specialized for the way Vanderbilt ran, that it didn't work anywhere else. And
Yeah.
because it had become so customized. And then you have the opposite with an EMR I won't name, that basically says, hey, it's going to work just how it is. And if you don't like it, tough. That's a little bit hard on that side as well, but their results have been a lot better.
Mm. That's great advice. We see it all the time from the VC side, is you have to balance having a vision, having a unique value prop, with also listening to the market and making sure it fits. So these are the
Yeah.
challenges to navigate. Yeah.
Yeah. Well, I hate to say it. If everyone could do it, we wouldn't be making this video.
Exactly. And so let's shift to the topic of navigating the stakeholder landscape within IDNs. And to start, you've personally held leadership roles across multiple health systems, and so I'm curious to get your view on, how has the chief clinical officer role evolved over time, and for startups trying to get their bearings, how does that role differ from and relate to, say, a chief medical officer?
Yeah. So And they call us different things in different places. So I spent a lot of time basically looking at products and saying this could work. Okay. And then I would connect you to the right people within the organization to see if it was interesting to them. Okay. Uh, and the other way around, they would find things, they'd sort of have to run it by me to make, because I saw the bigger picture on both sides. And so the chief clinical officer of an IDN should be doing a couple of things. Number one, getting you to the right decision maker from the standpoint of using the product and them thinking it brings value, which might be a CMO. Okay. And then also focusing on, okay, how do they connect the health plan and and the provider side or the care delivery side together, because they see the bigger thing. There are lots of times I've seen companies like some that might be watching this that I really thought we should use that I had to say no to because I couldn't get the buy-in below me. Okay. And I've had other ones where I've had to veto what they were doing because I saw a problem or but most of the time I said, have you talked to your colleague on the health plan side? No. Well, go talk to your colleague on the health plan side to make sure that it brings, over time as an organization, it brings value for both sides. Because otherwise, I'm going to have hundreds and hundreds of products that I'm not leveraging to their full capability. And so a lot of you've got to sort of figure out who that person is and how you get in. And sometimes it's less about um, who you start with than making sure that they are navigating and getting you to the right people. Because a lot of times you'll talk to somebody and go, "Oh my gosh, they're buying it tomorrow." Come to realize that they were just some doc that you happened to get hold of that really liked it. And
Mhm.
so, in any of your end of any meeting you have with anyone, if you feel the meeting goes well, if it's an IDN or any health system, you need to ask the question, who else do I need to be talking to?
Exactly.
And if it's an IDN, who should I be talking to on the other side? And can you set that up?
Yeah. And you touched upon two important subjects there. You mentioned that in your role, you not only were clinical, but you could see the wider picture and who do you speak to at the other side. So is it kind of accurate to say that at least in your system, a chief clinical officer was both serving the payer and the provider arm, and so
Yeah,
they would.
because I work for the system, and the system is the conglomeration of both
Okay,
all different components, right?
exactly. Yeah.
All different components. Now, it might be a hospital and the medical group. It might not have anything to do with the health plan side, right? But hopefully, you're talking to the person or a person that is having to think that broad
Yeah.
from a corporate standpoint. The majority of time, that's not your entry point.
Yeah, and so we spoke about it in the manual as well, but are there any other roles in risk-bearing IDNs that founders should probably look for or get to know as an ideal entry point? Titles or roles that might not even exist at standalone providers or payers. For example, where does the synergy realization responsibility typically sit or actually sit? Is it population health, operations, clinical leadership, something else entirely? I mean, help us navigate, where these people either go.
Yeah, unfortunately, I'm not going to be much help here because everywhere is so different.
Yeah,
Okay. I still run into this when I talk to my colleagues. It's like, okay, so what do you have responsibility for? What do you not have responsibility for? And so I wish it were that simple to say, hey, these are the titles of the people that are focused on everything. And it's very different because there are a lot of IDNs where the payer side is a very small piece
Mm.
versus others that I've been accustomed with where it's really much more 50-50. So it's a bigger thing. That gets back to our conversation earlier is really figuring out, are you talking to a true IDN or not?
Yeah.
Or
Yeah.
one that just says they are, but really not. And if not, then you just got to, that makes life a little bit easier because now you're just focused on one side or the other. But you know, you said something, and I'm a huge believer in it. And the consultative sale is very important. And consultative doesn't always necessarily mean you have to consult them. It's a way for you to learn about them that then helps you sell as well or helps you understand. So that's why I like what you have done with the types of questions. It's really designed, in my mind, the more knowledgeable you are about me, the better you can help me solve my problems. Because
Sure.
you know, I'm going to sidebar a little bit here and talk about language. Okay, um, I talked about try not calling my baby ugly. Try not telling me what I'm doing is wrong or stupid. Because if you make me feel like I'm not taking care of my patients, I will get very upset. Okay. So that's always very important. The other is understanding partnerships versus a strong vendor relationship. Okay. A partnership is very different. A partnership is when two different people are trying to help solve the other person's problem. Okay. And so if you're, you know, you might consider yourself a partner, but in reality, I'm just saying, no, you're just trying to sell me something versus a partnership is that I'm trying to help solve your problem while you're trying to help me solve my problem. And so, and there's nothing wrong with a strong vendor relationship. I mean, I've had incredible relationships with people that I don't consider a partner per se, but but the relationship is very good. So walking in saying we want to partner with you. Now I'm pretty much a jerk at times. Okay, if you came in and said that to me, now the reason why I'm telling you this is because they won't say it to you, but this is what they're thinking. If you came in and said to me, I want to be your partner to help you take care of people better, I'm going to ask you, okay, if you come in and do that, how much of your company do I get? Well, you don't get anything. Well, then we're not partners.
Sure.
Okay. Because I've got no skin in your game. And so I'm fine with you wanting me to buy something from you. I got no issues with that. And then we might get into it. I don't know if you're going to go this way or not, how to calculate that ROI for me or how I think about it. But at the end of the day, just try to when you go into a conversation, because some of you are will be at a part where you want a co-development partner, you want a partnership, but understand that when you say that, that means I need to get something, not just necessarily a reduction in a good price for something.
Sure, sure. And some of our startups, we've seen that they've been successful offering warrants to their first partners, which not only good
There's
for the buy-in, but also because usually the product at that point has all sorts of problems and they need to iterate and they need a patient
Yeah, because and you won't
centered
hear
approach.
people tell you this, but what they're thinking is, I've got to pay you to help you get better to sell to other people.
Early days, exactly.
Okay. And the reason why I'm bringing this up because you mentioned something earlier is most people you will interact with won't tell you how they're truly thinking about it. When you say this is what they're thinking, they're not going to say it, but this is what they're thinking.
Sure. I imagine, to take that framework further of partner versus vendor, if you're selling a solution that spans both sides of the house, the plan and provider, which makes alignment tricky, this is probably it's probably more important to come with a more consultative sale and to really partner more deeply because that organization is going to be so unique in terms of what
Yeah.
you need to bring to the table. And
And so I would frame that statement. How do you have a consultative conversation in order to be a better vendor?
yeah. And so what have you seen? I mean, when in these cases, and this kind of comes to the heart of the whole thing, and we talk about it in the manual, we call it buyer mapping, but when value shows up in one place, an operational lift somewhere else, this might not have a clean answer, just like the org structure question, but what have you seen work to get buy-in across silos? Do you work on both at the same time? Try to get champions on both sides that can align incentives.
In a true IDN, getting champions on both sides that understand the value. Because remember, even though we might see it bringing down our joint total cost of care,
Yeah.
I might want to use codes in order to collect fee for service dollars from a different vendor, from a different payer, right? So at the end of the day, I still need to show an ROI or a value, knowing that I only have that 10 to 20% overlap.
Hmm.
Okay. And the payer is going to want to use it as a value based arrangement with another uh, a provider side entity, right? And so, if you truly have or at least getting to the point of saying, do you see this bringing value to your payer side if you're going that way, or is it going to cause you problems? Let's talk and work through that. Or if you're starting with the payer side, are you going to run, how is this going to be viewed? Let's figure that piece out. But if you can get champions on both sides, that's where you really can hit a home run.
Yeah, I assume you have to be exceptionally well integrated, and it's pretty rare that you can get one champion to be willing to lose budget and revenue on behalf of the larger picture for
Well,
the org, right?
yeah, and we had run some of those numbers. We call it integrated we had called it integrated economics.
Okay.
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 And so those running that math does exist.
Mhm.
Okay. But that's after your consultative sell or consultative conversation to understand that the organization is thinking about it that way.
Sure. Sure.
Right. And then you got to realize what's hard dollars versus soft dollars.
Hmm. Yeah, I imagine you'll get thrown out of the room if you come with integrative economics and someone is not interested in that at all.
Correct.
Yeah. Two of the questions you added to the cheat sheet that might be interesting to touch upon was, does your provider side accept and want the attributed lives from the plan? And is the goal to create a closed loop model where the plan and provider primarily serve each other, or do both arms also operate independently in the broader market? This is within the incentive alignment.
Yeah.
How does that relate to your
Yeah.
experience at IDN?
Yeah. So I'm going to use the Medicaid example.
Sure.
Okay. You could have a payer that is in a relationship with the state on the Medicaid side, but the provider side doesn't want Medicaid lives. Okay. Versus saying, no, we really want to do well in Medicaid. How does this help us on both sides of that? Right. So understanding that. And then and I've alluded to it multiple times, understanding that both sides still have to work with other entities.
Yeah.
Okay, so in my example, how could this help the plan in their Medicaid book of business with other providers? And really understanding and it's really a test of alignment. And
Mhm.
so, for example, when I used to hire physicians, I had a balanced scorecard. One of my questions was, oh, tell me how, you know, are there payers that you don't like working with at all? And I would get the answer, oh, we really shy away from Medicare lives. Okay. And I'm going, well, I'm a faith based organization. where we need to serve everyone, especially the vulnerable, and a lot of those are in the Medicare or Medicaid book of business. Why would I can't hire you if philosophically you don't agree with our underlying mission?
Mm,
And
yeah.
so making sure that the missions are aligned is very just to understand, okay, am I cross-selling or not?
Yeah, even if there's overlap between plan beneficiaries and patients, it's always going to be just a portion, and
Yep.
you'll continue needing to balance the two. And as a vendor, you need, even if you're helping with that integrated business, you still need to take into account the rest of the panel, which is probably the majority. Makes
Yes.
sense. And you mentioned Medicaid, so it's a good lead into the kind of next subject. I mean, you've worked in markets with large Medicaid populations, and I think it's fascinating to explore the financial value equation that supports doing meaningful work in these communities that are typically seen as hard to reach and under reimbursed. And so what makes innovation in this space financially viable for an IDN, while it might not be maybe for some other organizations that don't have kind of both sides of the house?
Yeah. And most Medicaid now is managed care. Okay. And so you're getting a payment and you've got to manage everything underneath it. Those of you all that have helped think through how to get to that consumer are the ones that are going to do really well. Okay. So in the Medicaid world, the both the payer and the provider side, the biggest issue is trying to work with a very difficult population that are struggling just to get through day to day. So they're not focused every morning on how to take care of myself. Okay. They're focused on how do I survive? And so that's where it gets, when you begin to solve that and getting experience in the more difficult population, then you've really begun to solve for a health plan or a provider side problem. Okay. Because if it's a repeat customer that has Medicaid as a bad payer, I don't necessarily want them sitting in my ER because they're taking up a bed at a loss for me,
Mm,
right? And then the plan side definitely doesn't want them going to the ED because they're having to pay something and they're not getting their part. So Medicaid, there's very on the Medicaid side, there's very strong alignment because the provider side doesn't do well on Medicaid payments
mhm.
because it's designed that way.
Right.
Most of the time, there are some anomalies to that, but for most part, uh, keeping Medicaid lives healthier impacts both sides positively, and they're the hardest ones to keep healthier because of their quote diseases of life.
Mm. Yeah, and you touched upon, the we'll come back to the diseases of life, but also the engagement of these patients and how difficult it has been. And so how much, I mean, as a digital health VC, I do wonder sometimes how much of it comes down to good old fashioned blocking and tackling on the ground, being in the community with, the clinics and, setting up at the kind of right places that they're at versus, I mean, what is the kind of role or what is the room there for digital innovations to drive real impact in this population?
Yeah, I mean, at the end of the day, it's about activation and engagement. How do I activate and engage you in a way that works for you? And so, if you're dealing with a community that doesn't have broadband, that are the ability to do it, uh, or that has phone numbers that where your cell phone works 30 days out of the month, or you run out of whatever you've had and you can't use it, it becomes very difficult. The other issue is trust in those communities. Trust is a big thing. So focusing and working with your customers, meaning who's ever your paying you of how do I get into that population? How do I help you get into that population? Uh, Whether it is, gaming techniques, whether it's incentives, however different organizations and vendors think about it, that population is very difficult. Uh, and now with everything that's going on right now for us, not sure how that's going to look like from a payment side, from a government perspective.
Sure, sure. And so you mentioned also this diseases of life, the concept of, not only viewing people through a clinical lens, trying to better understand who they are as people. And it would be great, I think, in relation to this point on trust
Yeah.
and engagement, what does that actually look like at the ground level when you're,
Yeah, I think, and this is Jordan Asher's thesis and hypothesis of Western medicine. Okay, and that is we come at everything from a physiologic perspective versus a psychologic perspective. So I view you as a diabetic, and therefore this tool will help you a lot, versus you as a human being that is figuring out as a single mom how to take care of 4 kids, getting them to school and work 2 jobs, who, by the way, happens to have diabetes.
Mhm.
Okay. And if I and I think where we have failed is that we come at it from the physiologic component and we look at you as a disease, and all I have to do is educate you more and you'll do what I want you to do, versus saying I need to view you as a human being that has the diseases of life that you are more focused on, and how do I work with you within that context? And
Mhm.
it's flipping the focus of what you are trying to work on. And that's where I go back to activation and engagement, and that segmentation is around how do I as a human being respond to different inputs and to different things. What are my hooks? What drives me? And how am I better engaged? So it's very much a marketing view versus a healthcare solution view.
Mhm. And, another domain that you have a lot of experience with that relates to this because it's the economic model behind it is value-based care. And I mean, you started your career deep in this movement from volume to value. You've been doing this
Yeah.
work for some time now. But when you look at, the CMMI track record, there's still this open question, has value-based,
Well,
yeah.
yeah. So you're bringing up, and we fought this amongst my us a lot. Does value based care really work?
Yeah.
Okay, from a cost perspective. So a couple of components. Number one, value based care and value based payment models are not one and the same. Okay, value based care is how do I deliver quality plus service at a lower cost? Okay, uh, value-based payment models are a way to possibly support that. So just remember, they're not necessarily the same, because in fact, what we call fee for service as the antithesis of value-based care was initially created based on something called an RVU, which is a relative value unit. So it was designed to pay on value.
Sure.
Now, over time, that value turned into a time component and just a service component, but the concept's always been there. So, where have we gone wrong as an organization, as a healthcare delivery? Because I still believe in value based care and value based payment models, is because of the concept we haven't moved to thinking about you as a human being first and then a disease second. So I think we've come at it backwards. And then number two, and I am an internist, I am a primary care doc, we focus on primary care centric models. And if you follow the dollar, it doesn't work that way. So what I'm really saying is that, and this is very important, that if your product requires a physician to be in the middle, you're going to lose. And then you're going to say to me, yes, but you are everything has to go through the physician. And my point, primary care physician. And my point is that is where we have gone wrong. So if your product, or if you're designing, think about it this way. How well would my product help you if half of your physicians went away tomorrow?
Mm-hmm.
And if the answer is we're in fact can help you deliver care in a way that is consumer focused, and you don't need physicians to be in the middle of it, then all of a sudden you have a winner. Because, people would ask me, Jordan, what do you think about every night when you go to bed? And what I think about is I have a mission to improve health, right? I, if tomorrow half the doctors became science teachers, my underlying problem does not go away.
Mm-hmm.
So I need to be solving for that problem, not solving for how to get a physician to use my tool.
Mm-hmm.
Okay, because physicians are incredibly important to diagnose and treat. However, the model falls down where everything focuses around that. So when you think about primary care services versus primary care physicians, you don't have to do all those services through the physician. So a lot of the things you all are creating is in a model to say, I don't want to call it disrupting the physician, but how are you taking care of a person working, as a wraparound to that physician, not through that physician?
Mm.
Because you talked about attributed lives. At the end of the day, I'm sure many of you have heard of the concept of a patient-centered medical home, right?
Sure.
However, that patient-centered medical home is how I treat you in my office. How disingenuous is it to say that your medical home is my office?
Yeah.
Your medical home should be wherever you are, however you live your life. And my office might be a room in your home.
Mm-hmm.
So that gets to the point that you were bringing up, value-based care, and it's CMMI. Because I think whenever something doesn't work, it's for one of two reasons. Number one, you have not implemented it well, or number two, your underlying hypotheses are wrong.
Mm-hmm.
And I think for us, and why I'm so excited for you all, is that I believe we have tried to continue to try to implement it correctly, and it still hasn't worked well. So it's now time to question our underlying hypotheses.
Mm.
And as you all are creating things that work in a different hypothesis, that's where I think there's going to be incredible value.
Mm-hmm. Well, that's a great point to kind of conclude the conversation, a great high note. And I think, before we sign off, maybe you can give us your take on why founders and investors and innovators in the digital health arena, despite all this complexity around IDNs and all this, challenges of incentives and really navigating these organizations, why they should really be paying close attention to them as a budget holder for innovation in healthcare. Why they should really prioritize this segment, even though it's not the easiest to sell into.
Yeah, I think you should I'm not going to call it prioritize this
Or
segment,
when they should
because,
prioritize it.
but realize at the end of the day, uh, you're either an IDN as an organization, or you're going to be in an IDN type of relationship with a payer.
Hmm.
Okay. And so it's important to understand this, regardless of it's within one entity or it's a separate entity that is then negotiating in a value based way with another. Because then at the end of the day, even if you're not one and the same, over time, you're going to be taking delegated risk.
Mm.
Okay. And so, no matter who you're working with on either side, is going to have to think about it in the same way, whether it's a single entity or not. So by focusing on IDNs, you sort of get the breadth of the knowledge you need, even working with separate entities, because that's how it's going to have to go anyway. Okay. This separate fighting with each other is not a survivable model. It's just
Mhm.
not. And so understanding that world, I think, is incredibly important. And an IDN has the most to gain from a value proposition of your products.
Mhm. That's such a good point. It's almost like a microcosm of the incentives of the broader
Correct.
healthcare system. You always need to understand the intersections between them, the misaligned incentives,
Yeah,
and
that's exactly right.
yeah.
So an IDN is trying to own it, both sides, to try to figure it out, versus you still have the same exact dynamics in a contractual relationship.
Sure, sure. That's great. That's great. Thank you so much. How can viewers of this video go about best getting in contact with you and following your work?
Feel free to contact me. My email is jrasher, JRASHER 007 at gmail.com.
Great. All right. Thank you.
Thank you. Have a great day.